This is a program that is sponsored by the Newport Beach Public Library Foundation in conjunction with UCI Health. And we have two people who work very, very hard to bring this to us. One of them is Kunga, our program director, and the other one is Jane Merritt with UCI Health. So please give them a round of applause. As well as for Jerry, our CEO, who's been doing a brilliant job of leading this capital campaign for the building of Whitty Hall, which you all drive around and find a place to park around as you come here. So we'd like to thank always our generous sponsors, Mike and Polly Smith, who have been with us, sustaining us since this program was founded. They are not here tonight, but their daughter Jan is. Jan, would you stand up, please, so we can acknowledge you? So it's just wonderful to know that this family supports us so totally and completely. A quick bit about us. The Library Foundation is a membership-driven organization. How many of you are members? Well, we'd love to have you join, and we're even going to have a little special item for you to get you to join if you haven't. The new members in the next few months will be invited to our summer solstice on June 18th, which is a lovely event with the Library Foundation board and our major donors and our members, and it's a good way to come and be a part of the community. So put that in your mind and see Kunga afterwards and become a member. So our program tonight's going to conclude with Q&A. So we request you hold all your questions until the end. If you have a diagnostic issue, it would be best to talk to our speaker after the program rather than probably, this is being videotaped and it goes up online and on YouTube. So just bear that in mind when you're asking your questions. So I'm pleased to introduce tonight's speaker, Dr. Zeljka Jutric. She is a board-certified UCI Health surgical oncologist who specializes in liver, pancreas, and bile duct surgery. She earned her medical degree at the University of Nevada, Reno School of Medicine, followed by a residency in general surgery at Swedish Medical Center in Seattle. She completed fellowships in hepatobiliary. I practiced that word and now I'm not, I'm screwing it all up, and pancreas surgery at Providence Portland Medical Center in Oregon, and surgical oncology at the City of Hope in Duarte, California. She performed the first islet cell transplant in Orange County in 2019. She won't be talking about that tonight, but she says it would be a good topic for another meeting. I want you to see that I'm wearing a colon cancer awareness ribbon that I was given when I came because Jane very thoughtfully arranged this program tonight on this particular subject because the month of April is the celebration. So get your ribbon on the way out. So let me invite Dr. Jutric to come up here.
Thank you so much for the kind introduction and welcome everybody. It's an honor to be here with you tonight. So I'm going to be talking about colon cancer that spreads to the liver. That's a topic that I'm very passionate about, and it's a disease that I most commonly see in my practice. So we're going to talk about colon cancer and liver metastases. I'll go over some general aspects to this. We'll cover some questions like why we get cancer in the first place, what the risk factors are for colon cancer specifically. And then one thing that I'll really focus on is this paradigm shift, which is really important in the treatment of liver metastases. And then we'll talk about surgery for colorectal cancer and how it has evolved. And then we'll talk about some other treatments such as hepatic arterial infusion and histotripsy for patients who cannot have surgery up front. So this is our team of surgeons at UCI. This is Dr. Imagawa. This is Dr. Imagawa, who has been at UCI for a really long time. I joined him 8 years ago, and then we just recruited a new surgeon, Dr. Ayabe, who came to us from MD Anderson and just started in October. So we have a really great team. I love working with them. So colorectal cancer is the third most common cancer. It's behind lung and breast cancer, but it's the second result for cancer-related deaths. So it's the third most common, but the second, deadliest, I guess, for lack of a better term. And then a lot of these patients that get colorectal cancer will have it spread to the liver, about 50%. And in the more recent literature, it's actually up to 60%. So a lot of patients will have it spread to the liver. A quarter of these patients will present at the same time. So at the time that they're diagnosed with colorectal cancer, they'll already have spread to the liver. And then the rest of the patients will get it at some point of time in their diagnosis. So maybe they had colon surgery, 2-3 years ago, and then on their surveillance scan, or after, their blood numbers are abnormal, we'll get a CAT scan and they'll have liver metastases at a later time. This cancer also spreads to the lung. And so I thought this might be interesting to kind of bring up. Why do we get cancer? This is something that my patients ask me all the time. And really the truth is, for the most part, it's bad luck. Cancer is kind of a process of aging as the cells turn over. So cancer develops due to the accumulation of genetic mutations in important genes that control cell growth, division, and importantly, DNA repair. So as we age, our cells turn over and over and over, and so mutations get introduced. And if you have a mutation in a gene that repairs DNA, then that could become a cancerous cell that then divides and divides. So that's the endogenous part of it. So that's just an error in DNA replication. That's something that we cannot control. There's also exogenous factors. These are the environmental and lifestyle exposures. These, I would say, are much less contributory, because we have a ton of patients who are perfectly healthy. They're fit, they exercise, they eat well, they try to limit processed foods, and they still get cancer. That's another thing that, people ask me all the time. Mom is in the best shape. She's never smoked, never done anything. Why did she get this? So for the most part, the answer is that it's bad luck. It's a, natural process of aging, but there are some environmental exposures that we can control. The biggest of these factors is chronic inflammation. So if you think of a lot of cancers that people get, like esophageal cancer, a lot of that is result from GERD. So that's ongoing, acid that inflames the tissue. Inflammatory tissue replicates over and over and over. Same with cirrhosis. That's a state of inflammation. So anytime that an organ is inflamed, it's trying to always repair itself. So the more repair that it does, the more likely a mutation is going to be introduced. So that's one thing. For colorectal cancer specifically, there are some genetic components. There's Lynch syndrome, one of the hereditary components. There is an aspect of family history. So if you have a family member that's diagnosed under the age of 50, we screen those patients earlier because there are some associations with familial components. Inflammatory bowel disease, that's a really big one. Crohn's disease, ulcerative colitis, those are definitely risk factors. Prior radiation. And then the lifestyle and environmental factors, it's, kind of the Western diet, processed foods that causes inflammation, obesity linked to metabolic syndrome and insulin resistance. But again, those are a lot less likely to be the reason, and we can never really pinpoint any of these. I only included this. This was actually in a paper that sedentary behavior is more of a risk factor for rectal cancer, and they included TV in there. So I pointed that out to my kids just as another reason that they shouldn't watch TV. And then smoking and alcohol are things that cause inflammation. So one thing that is alarming is that this cancer is definitely increasing in patients that are younger. And even in my time, so over the last 10 years of working in this field, I have definitely noticed patients that I see now that are much younger. So it used to be, when I first started, if I had a patient in their 30s or 40s, it would be kind of a big deal. Like I would, be super alarmed about it. But now I'm regularly seeing patients in their 40s, So it definitely is increasing in younger patients. And one of the theories for this is that there is a higher and earlier exposure in that generation to, pro-inflammatory processed foods. Again, obesity, type 2 diabetes, the whole metabolic syndrome, genetic and familiar factors. Still, most of the cancers are sporadic, meaning they're not familial, but there's definitely a higher association with familial components in patients that are younger. There's a factor of delayed diagnosis. We see this all the time still. Somebody that's 35 has rectal bleeding. They're told it's hemorrhoids. They don't get a colonoscopy. They keep bleeding. And then, of course, eventually they get a colonoscopy and they have cancer that's maybe more advanced than it should have been. So anybody that I know that has any inkling of any blood in their stool, I tell them to get a colonoscopy off the bat. It does not matter how old they are. They have changed the age of colonoscopies to 45 years, but still a lot of these people are in their 30s that are getting cancer. So I'm sure eventually it's going to get even lower. There's another interesting theory, and that's the use of antibiotics and how they alter the gut microbiome. There's a lot of research being done on that currently as a potential environmental exposure to why we're seeing so many younger patients for colorectal cancer specifically. I don't know that it's necessarily true for other cancers, but it's definitely true for colorectal cancers. And then, so that's kind of how we get cancer, and then how does cancer spread? So there are a couple of different ways. Hematogenous, so cancer cells enter the circulation, sometimes even before they're discovered, because that's another thing that I hear a lot. Well, we took the cancer out, why did it spread? And it's not that we left cancer cells behind, it's that they seeded the blood circulation and they got seeded into the liver and were dormant for some time, but that process happened before maybe even diagnosis. So that's one of the ways that it spreads. It enters the circulations, spreads to distant organs. Lymphatic spread is another one. Lymphatics are channels that cancer can invade, and then they are connected to the bloodstream. Then it becomes hematogenous spread. Peritoneal spread is another one. So there's the peritoneum is the lining of the inside of our abdomen. It's a really kind of shiny, soft lining that coats all of the organs, and cancers can seed that way too and spread within the abdomen. Implant on peritoneal surfaces. There's direct invasion. This isn't necessarily metastatic spread, but that's when a tumor invades into nearby organs. And then there's nerve-related spread, where cancer spreads along nerve sheaths. That's called perineural invasion. But the most common one is the hematogenous spread. Okay, so this is my favorite topic, this paradigm shift. And I bring this up because, before, it's been quite a number of years that we've been removing these metastatic cancers. But, say in the 70s, it was completely crazy to think that you would remove a cancer that has already spread. So even in my training, I used to hear all the time, and maybe still to this day, we hear, the cat's out of the bag, the cancer has spread, so there's nothing to do because it's beyond our control. That's something really common that we talk about. And then people started viewing cancer that has spread kind of different based on what the origin is and what the pattern of spread is. So there's this huge paradigm shift where stage 4 cancer actually can be cured and is cured on a regular basis, not for everybody, but for some patients definitely. And I remember when I was in training, I was at a national meeting watching this presentation, and the person presenting mentioned cure in the same sentence as stage 4 cancer, and people got really uncomfortable. Somebody even got up to the microphone and was really upset, saying, how can you say that, stage 4 cancer can be cured? So it's definitely a paradigm shift, and even though it started many years ago, I think we're still quite a ways, behind it being totally acceptable and known that stage 4 cancer can be cured. And in fact, I see it all the time in my clinic where people come and say, I was told this could never be removed by X number of people. So I think even though it is well accepted, well documented, there is still a lag kind of in the medical community to which cancers can be cured or not at the stage 4 level. So the short answer is yes, it can be. It depends on the cancer type. It depends on the mechanism of spread. And of course, it depends on the patient's overall health. Can they tolerate surgery, chemotherapies? Oftentimes, stage 4 patients will undergo a number of different treatment modalities. Usually it starts with chemotherapy and then, gets moved on to surgery, radiation, et cetera. And this is a really famous quote in surgery: a chance to cut is a chance to cure. That still holds up in some truths, in that surgery is kind of the ultimate goal for removing cancer, and you can't really cure it without surgery for this cancer in general. But it's not true in the sense that we really can't do it with just surgery. Usually it involves multiple different treatment protocols. Sometimes it takes a year for these patients to complete all of the treatments necessary to get to the potential of cure. But it turns out that for colorectal cancers that have spread to the liver, surgery is extremely effective. And this goes back to an idea that someone had many years ago, in that the liver is kind of the last lymph node of the abdomen. So the liver, all the blood flow from the abdomen, including colorectal cancers, all gets filtered out through the liver. All the blood return goes back to the liver, and then it goes on to the rest of the circulation. And it turns out that the liver is a really good filter. So if you think about it, it filters all sorts of things, chemicals, medicines that we take, et cetera. It's also a really good filter for cancer cells. And there's a lot of, immune cells within the liver too. So if the cancer goes to the liver and stays there, those patients have a much better biologic profile for achieving cure. If the cancer goes to the liver and, say, the lungs, the chance of cure diminishes a lot. Still possible, but it's a lot less likely. And surgery works really well for this. And then, like I said, it's especially true when the liver is the only site of this disease. And then this is my favorite analogy, is really thinking of it as the last kind of big lymph node of the abdomen, and it being a really good filter for many things, including cancer cells. So that's a really neat idea that was thought of many years ago. And again, it's really truly is a paradigm shift. Okay, so when we think about colorectal cancer with liver metastases, the definition of cure is a little bit different. Usually at 5 years, if you're cancer-free, we consider that the gold standard for cure. The cancer is very unlikely to come back after 5 years. But for liver metastases specifically, it's 10 years. So I tell my patients the highest chance of it coming back is within the first 2 years. And then once you reach 5 years, it becomes less likely, but it's not until 10 years that we can truly report a cure for metastatic disease. So this is one of those survival plots. And then another reason that this kind of criteria for who can have surgery and who can't have surgery lags a little bit is because the criteria for resection have changed a lot. So when we first started doing these liver surgeries for metastases, which again was a big deal in and of itself because it was kind of, really out of the box to do that, It used to be that they would do it only for if the patient had one tumor, if it was less than 5 centimeters. People thought that it would not work if the tumor was on both sides of the liver. It turns out that that's not true. What is true that the more tumors you have in the liver, the higher the chances that you're going to have more tumors after the initial surgery. But how many tumors you have in the liver is not the driver to decide whether you can have surgery. So the modern criteria that we use now, so when somebody comes in and I look at a CAT scan, they have a bunch of liver tumors, I look at what part of the liver can I save. Uh-oh. Do you know what happened to the... Oh, here we go. I was talking too long and got tired of waiting for me. So what we look at now is I look at a CAT scan and I focus on the parts of the liver that don't have tumor in them. And I don't really pay so much attention of which ones do, because I'm really trying to find a way to leave that patient with enough liver to survive. And then we have a couple more criteria, like we have to have two of these liver segments right next to each other. So like we would have to leave these two. We couldn't leave this one and this one. So 2 of them have to be next to each other. They have to have good blood flow into the liver, good blood flow out, and the bile ducts have to be in continuity. So this is one of the parts that I really love about my work, is it allows me to be somewhat creative and really come up with a plan, some way using all of these different therapies that we have to clear somebody's liver and have it be healthy in the end, of course. So this is an example of a 54-year-old patient that I saw many years ago who had colorectal cancer, and she had this really large tumor and then a smaller one. She had chemotherapy. We had pretty good response where it had shrunk, and then she had another little tumor right here. So for this, I removed this part of the liver, and then I did burning, microwave ablation, which I'll talk about, on this other small tumor because it met the size criteria for that treatment modality. And that helped us save more of her liver so that she would have more to live with. And this brings me to the next point, why early surgical consultation is important. So we always talk about this multidisciplinary approach. I don't know if you have heard of it as well. So a multidisciplinary board is just a bunch of different specialties like medical oncology, surgical oncology, which would be myself, radiation oncology, pathology, lots of different doctors that sit on this board. Ours in particular is every Monday at noon. And we present cases, and then we talk about, for this patient, what do you think? Should they have this much chemo? What kind? What are their mutations, et cetera? And we come up with a plan together. And that's because too much chemo can be damaging to the liver, so we don't want them to get too much chemo. Too little chemo might not get a good enough response. So it's really the combination of this whole team that we work with that is very important in making these decisions, because sometimes, a little bit too much chemo might put somebody out of the window of having surgery, or, the wrong type of chemo might cause them to progress, et cetera. So it really, part of what I love about doing this too is working with a team of experts that really know all these different factors. And then, of course, colorectal surgery we work with very closely too, because a lot of times we do the surgeries together. So they take out the colon part, and then I do the liver part, oftentimes at the same time, to save the patient from having anesthesia and surgery twice. And again, this is important for timing of resection, and really the ultimate goal is to kind of reduce the number of patients who are out there not getting their proper treatments. So it's really to expand the population of patients that can undergo a curative resection, because the cure is possible. It's just sometimes patients are not getting, to that point for various reasons. This is work that I did back in 2020. We looked at patients who have stage 4 colorectal cancer. This was based on a registry, so it's pretty inaccurate data. But we found that 10% of these patients had surgery. And we know that more than 10% are able to have surgery, you know? So there's still a lot of work to be done in this area. And then, of course, my personal favorite topic is how liver surgery has evolved. So the liver has a lot of blood vessels. It's a very vascular organ, and it used to be that liver surgery was, you know, a big bloodbath. It was really scary for most people. You know, patients would die from liver surgery, and that has changed so much where we do liver surgery in a minimally invasive fashion, so through small incisions. I was recruited to UCI 8 years ago to start that program because we weren't doing it before that. We have a lot more ways to measure liver volume that are more sophisticated. We even have ways to augment liver volume, which I'll share, and then our patient selection has become a lot better. So this is the ablation down here. So we use ultrasound to find the tumor in the liver, and then we target it with a long needle, and then it's literally killing the cells with heat. It's called microwave ablation. And then this is surgery. This is a liver surgery that I did at the VA, actually. This is the tumor right here. This is the remainder liver there. There's a CT, a CAT scan way to measure how much volume a patient is going to have left over. And our general rule is that they have to have about 30% of their liver volume if they've had chemotherapy, which means that we can take out 70% of the liver, which is pretty amazing. And that's because the liver has the ability to regenerate. As you probably know, it's one of the few organs that can do that. And it's not that you grow a new liver, it's just that the remaining liver gets bigger. So you're not gonna, if we take out the right side, that side's not gonna regrow, but the left side of the liver will grow. So basically we, have this whole mapping system where we map out which parts exactly will be removed, what will stay, and then based on if the volumes are low, then interventional radiology passes a catheter, and they actually block, this is the blood flow into the liver, they actually block the blood flow with a coil embolization. It's like this big long wire that they put in, and they block the blood flow to the liver that we're going to remove, and that redirects all of the blood flow to the liver that's gonna stay, and we actually then measure the volume after that to see how much growth somebody has had. And there's all sorts of different calculations for that, but it's a really good measure of whether somebody who's on the borderline, who's had a lot of chemo, who maybe has some liver damage from before, it allows us to determine whether that patient is safe to have surgery, whether their liver has the ability to regenerate. So that's really, really neat. We actually do this quite often because a lot of our patients have advanced tumors. They've had a lot of chemo. They need some volume help. So this is what liver surgery used to look like with a big incision. We still do this quite often. I mean, I would say about only, in the best centers, we do about half at the most liver surgery laparoscopic because still a lot of people have huge tumors. They have multiple tumors. We're doing it through the small incisions, doesn't make sense. But we do a lot of liver surgery through small incisions, which before was so hard to imagine. And in fact, when I first saw it as a trainee, I thought there's no way, this is like impossible to do. But it is actually possible. And I was just at a conference, at our national conference this weekend, and I heard this quote, well, we'll be the witness of change or the architect of the future. And I thought that was really neat because we're definitely wanting to be the architect of the future and push some of these advanced techniques forward. So this was one of my first minimally invasive liver surgeries at UCI. Here, this patient's still alive. He actually has lung and liver metastases, and I did his surgery right when I started at UCI almost 8 years ago. He was somebody that was told that, he could never have surgery, had multiple sites of disease. His disease did come back in the lung, but was managed with radiation, and he's totally fine now. So we have a lot of tools in our toolbox. One of the newest tools is the robotic surgery platform. Have a lot of people in the room heard of robotic surgery? I'm sure you have. So that's surgery it's a tool that we use for minimally invasive surgery. So when I started, it was laparoscopic surgery. So it's you have two straight sticks that you do surgery through, and the angles can get kind of tough. The robot was developed to mimic like open surgery. So it has these wristed instruments. So this is the patient here, and this big thing is the robot. And then the surgeon operates the robot through like a separate little console away from the patient. So this was my first robotic case at UCI. This is our robotic rep who was very excited for that day. Yeah, Da Vinci. Yep. It became really popular with prostate surgery, and now it's kind of moved on to different areas, including liver. Liver has been kind of slower to adopt just because of the complexity, but it's come a long way now. When I started training, they were doing about maybe 5% of the liver surgeries were done through the small incisions, and now it's 10%. So I mean, still, then that's nationwide. In my practice, it's about 50-50, but nationwide, about 10% of the liver surgeries are done through small incisions. So some progress, but definitely not as common as some of the other platforms. And then this is my favorite instrument, the CUSA. I'm going to show a video of it. So another reason that liver surgery has become a lot safer is because there's so many of these tools now on the market. This is an ultrasonic device that allows us to really dissect these blood vessels, which I'll show soon. This was a really young patient, a 16-year-old girl that I did liver surgery on recently, not for cancer, luckily. But this is another example of removing this size tumor through these incisions. So it really has come a long way. And the reason it's important is not just for cosmesis, but it's really because patients have less time in the hospital. And for somebody who has to go on to get, chemotherapy, radiation, a second surgery, who's going to be under treatment for a year, it is really nice for them to have surgery that's easier to recover from. It really makes a big difference for them. So that's the biggest reason to do it. So this is a video of one of these. This is actually a laparoscopic surgery. And then this is that ultrasonic device that we use to dissect these blood vessels. These blood vessels don't look that big, but they hold a lot of blood volume. So this is one of them. So that could result in several liters of blood loss. But this really fine instrument lets us kind of find all of these blood vessels so that we don't injure them during liver surgery. So surgery, and sorry if anybody has a sensitive stomach, but it has really become a lot safer through all these various techniques that we have. These are some of the mortality rates. So in the 70s, if you had liver surgery, there was a 20% chance that you were going to die from the surgery. In the 80s, that came down to 10%, 90s, 5%, and now in our era, it's about 2%, and maybe even less, I would say, depending on all of the other factors. So it really has become a lot safer through all the work that a lot of different people have done. Okay, hope everybody's still doing okay. We just have 2 more topics to cover. One of them is the hepatic arterial artery infusion pump. So I brought this program to UCI a couple of years ago in 21 or 22. We were the second UC site to open this program, and we're the only program in Orange County that implants these pumps. So it's basically like a portacath, but it's in the abdomen, so it's bigger than a portacath, and it allows us to deliver chemotherapy directly into the liver. So it's the little catheter, instead of going into your bloodstream, it goes into a blood vessel that goes directly into the liver. It's a special type of chemotherapy that we use for that. Oftentimes patients also get systemic therapy with it, but we use this a lot for people who cannot have surgery at that moment. So they have too many liver tumors in all parts of the liver, and we use this to shrink the tumors in order to get them to surgery. So this is a picture of what it actually looks like. This was my first case at UCI. At the very end of it, we put in some blue dye into the pump, and then we make sure that all parts of the liver turn blue so that the whole liver is getting the chemotherapy, and we know that when we leave the operating room. And it allows the 99% of the chemotherapy to be uptaken by the liver. So it's a very efficient way to deliver chemotherapy. So that's a really exciting program that I'm very proud of at UCI. This is another kind of up-and-coming, really popular ablative tool called histotripsy. It's like this whole kind of complex setup. This doesn't even involve any incisions. So this does not involve any cutting of the patient. The surgeon or radiologist controls this ablative tool from this console here, and then this is an ultrasound thing that's delivered through a water basin that sits on top of the patient, and it creates air bubbles that then destroy the tumor cells. And then the final thing that I'll talk about is precision medicine. So this is the belief that the individual tumor biology is the ultimate driver for how patients do. So we have a lot of ways to do molecular analyses, both of the tumor and of the blood. We look for different mutations that then we can target with different chemotherapies. It helps guide systemic and surgical treatment. It gives us clue to prognosis of a patient, and there's a lot of talk in using artificial intelligence to kind of help with some of these analyses in the future, and probably in the surgical realm too. It'll never replace surgery, but it's going to help make surgery better. So in summary, colorectal cancer with spread to the liver is common. Remember, colorectal cancer is the third most common cause, and over half of those patients will get spread to the liver. So we see this all the time. It used to be really impossible to cure, or even hard to imagine to cure these patients. And today, the outcomes really are improving, and a lot of patients are getting cured. The criteria for resection have changed a lot. The team of doctors to treat these patients is really important. And then liver surgery has evolved. It's safer, it's less invasive today. There are other treatments when upfront surgery is not possible, like that liver pump that I showed and histotripsy. There is some role for transplantation. That's quite limited, but it's a possibility. And then our goal is to get more patients to surgery so that they can go on to live, have all their goals met in life. And then in summary, I'm a surgeon, so for me, the liver tumor belongs in the bucket and not in the body. And then just a few slides about myself. So what I love about my work is really, it's such a privilege to be on this journey of fighting cancer with patients and their families. That's something that brings me so much joy. And then I get to train the new generation of surgeons. So all these people here are fellows and residents that I train. They're a lot of fun to work with because they ask a lot of questions. So you really have to be on top of all the new data, and you have to go to meetings and bring all the latest and greatest to them because they're very curious learners. And then it's a privilege to innovate, to bring, programs such as robotics and the HAI infusion pump. So that's all things that I do at UCI. And then when I'm not doing that, I'm trying to keep up with these two. And I'll take questions. And I also want to point out two special people in the audience, and that's my mom, and then Miss Judy Graves, who is an awesome educator of children in this area. So thank you all for coming.
Thank you, Dr. Jutric. So we will have questions, and Kunga and I will be coming around. And who's first? I think we're overwhelmed looking at that liver. I can't imagine doing the surgery. It had to be such a learning curve for you to navigate the complexity.
It's a long training path. So after medical school, I spent 8 years just training to do liver surgery. So it's a long, road. So we always say that's why it's a 5-year program, that's why it's an 8-year program, because it becomes, kind of automatic. It's easier to do that than, for me, than like some other things. So
And other things.
yeah, just a lot of years.
Well, we really respect it. Oh,
Thank you.
I have a question about the symptoms. Is it just mostly bleeding, or are there other symptoms that alert you to the fact you need to have something checked out?
Usually there's not a lot of symptoms. There can be weight loss, but that, a lot of times happens later. It's usually bleeding or something else. Sometimes people have symptoms of diverticulitis, for example, where the tumor perforates and it mimics pain. That's not that common. Most of the time it's just that either found on routine colonoscopy or they had bleeding.
Jan?
Thank you so much for the presentation tonight.
Thank you.
I was really interested in what you said about transplantation. I just would have assumed that wasn't an option if it's already kind of systemic. How does that work?
That's a great question. So it's a very limited number of patients that are eligible for it. Of the patients who have liver spread, it's probably about 5% that we can refer to transplant. And it's the reason behind that is twofold. One, it has to be unresectable, so the tumor cannot be removed by surgery. And with all these different methods, a lot of times we can get somebody to surgery after chemo, after using the pump. And then it has to be confined to the liver. There cannot be any enlarged lymph nodes, anything like that. And they have to be stable for 6 months on chemotherapy. So the patients that get transplanted ultimately is a very narrow role. But I have sent a couple of patients for transplant referral. None of them have actually been transplanted. And even those patients will have recurrence in the new liver because it's impossible to, because of the micrometastatic cells that lurk around in the blood. They still have recurrence. But it is a very narrow window of patients. That's why I didn't spend a lot of time on it.
Do you deal with esophageal cancer too, or not?
No. Mm-mm. That's my partners do.
More questions?
I was wondering if you can speak about NASH. It seems a lot of people have that.
Yes, NASH is definitely common. So that's the non-alcoholic steatohepatitis. It's common. It's not necessarily linked to obesity. I have plenty of non-obese patients that have it. It's probably a genetic / again, inflammatory thing. It is thought that it's going to replace hepatitis as the number one most common need for transplant, like by 2050. So it's definitely on the rise. There's not a ton to do about it other than diet modification and things like that. It's something that we just keep a really close eye on. Liver biopsy is one of the tests. Usually there'll be some abnormality in the liver function test. They can do fibroscans too that look at it, and then ultimately a liver biopsy. But there's a lot of tests before that, like the fibroscan. And that wouldn't be done until, later, until there's some actual visual changes in the liver. No, usually, it's a thing that's seen on imaging as kind of an incidental finding, or maybe somebody has just a mild increase in their liver function test on routine scan. For most of these things, once you get to the symptom stage, it's kind of an advanced thing. So the hope is to catch it before you have symptoms. But there's so many people, it gets read on so much imaging. I think it's a little bit over-diagnosed on imaging. It's still not really common to see cancer as a result of NASH. I don't see it very commonly. The thought that it's going to be a common reason for need for liver transplant is because, we're treating hepatitis C and those things now. but it's not really, really common to see cancer from it. I don't think it really goes away with diet. That's why it's a very complex, phenomenon where we can't really pinpoint. I think more than diet is probably some type of unknown, like hereditary genetic component to it, because there's such a wide variety of people that have it.
Is most of this work going on at the CDDC or here in Irvine?
Most of our research is done at the CDDC. We do have collaborators on main campus. So usually I work with several different labs on the main campus, and the thing that we have is tissue. So we work with them to get tissue for their labs, and we collaborate on ideas, et cetera. They have the time and the infrastructure to do the basic science bench work, and we provide the specimens, kind of the clinical guidance for it.
Is fusion MRI used in your area?
We don't use fusion MRI so much, but interventional radiology does it. We use ultrasound, so a live, real-time ultrasound at the time of surgery a sterile ultrasound that we use to identify the tumors. But we use a lot of MRI. We love MRI and liver, but we don't ourselves use that much fusion imaging. Interventional radiology does, though, for their ablations, because we can see it real time. These are great questions.
Oh, if someone had, say, colon cancer, what would the symptoms be to look for if it's transferred itself to the liver?
So everybody with a newly diagnosed colon cancer gets CAT scans of the chest, abdomen, and pelvis. So that's part of the staging. So once you have a new diagnosis, immediately you get those studies, and then it's really just a finding on imaging. Because again, most people are not going to be symptomatic, but it's part of the staging workup for every newly diagnosed cancer.
So there's no real symptoms?
There's really not. I mean, for colorectal cancer, there is the bleeding, some weight loss, narrowing of the stools, from the mass itself. If the mass is bigger, there can be weight loss. There can be some abdominal pain or changes in bowel habits. But for a lot of people, there's not a lot of symptoms necessarily. I think the younger patients present more commonly with symptoms because they don't get screened, But sometimes these cancers are found on screening colonoscopy. So it is very important for everybody to get their screening colonoscopy and to not wait. And again, I tell everybody that I know, my sister-in-law, whoever, if they mention anything, I'm like, just, you have bleeding, you need a colonoscopy. Even if it's like the smallest speck of something and they're not sure if it's something they ate or if it was true blood, they need a colonoscopy, because the earlier we can get people to colonoscopy, the better. And at least that way you kind of know what's in the colon. Does somebody have a lot of polyps? Is this somebody we should screen more frequently, et cetera? And it's a really safe, very widely, easily accessible test. And they're even getting so much better with the bowel preps. It used to be that you had to drink, a really large volume of something. There's like more sophisticated ways that they bowel prep nowadays.
Quick question. My doctor said after age 80, there were no colonoscopies necessary. Is that?
I don't agree with that. I think it depends on the patient's physiologic age rather than their true number age. So if you're 80 and you're really healthy, you have a long time to live. So of course you should I think you should get a colonoscopy. If somebody is 80 and they have a million comorbidities and they're much more likely to die from their heart disease, from their CHF or something like that, sure, maybe on that person they won't be able to have surgery anyway. But if people are healthy, like especially in this area, there's a lot of healthy older patients who are taking care of themselves. They should definitely still get a colonoscopy. Because what if you find something? I mean, that could be a laparoscopic surgery, and then you have, the rest of your 80s and 90s to live. No problem. I think until what makes sense. I think it is probably, physician specific. I'm sure there are doctors that feel that way. I really think, and what I've learned from being in practice so far, that's really your physiologic age that's important. Because somebody in their 60s maybe who's really unhealthy, shouldn't have surgery. Like maybe they're not a candidate for liver surgery. For liver surgery, you do have to be pretty, in okay shape. It's high risk surgery. It's a big stressor to the heart. So I think it really just depends on how the person is doing, physiologically.
Is a 5-year interval for the colonoscopy sufficient if there's, for instance, family history or 10 or more polyps?
It's either 3, 5, or 10, really dependent on the individual factors. The people who have nothing, 10 years is fine. Adenomatous tissue that you might find at the time of colonoscopy does take a long time to progress to cancer. These are things that take 7, 12 years to mutate into a cancer, which is another reason colonoscopy is effective, because if you remove a polyp that's high risk, that could have totally prevented a cancer 10 years, 12 years down the road. So it just depends on the family history, like you said, and the number of polyps. I think if somebody has a totally clean colonoscopy and they do have a family history, you probably don't need to do it in 3 years. Probably 5 years, though, for that person. I think 10 years with a strong family history is probably too long. Mm-hmm.
I really want to talk to you about the younger patient, like our college age.
Mm-hmm.
Because so much is said, you do your colonoscopy, what's the age, 45? Or it could
That's
be 40.
the new age, 45.
Well,
Mm-hmm.
what about those kids that are running around in college or who have just gotten out of college and they think this is ridiculous?
Mm-hmm. Mm-hmm.
I think they need a lot of education. Do you feel that they are getting the message?
No, I
Or
mean, that's
not?
a great point. I mean, it's
Yeah.
still not so common where it's going to make sense to screen everybody at that age. I think, though, that there has to be a lot of education, of the first line providers who might see an 18-year-old with blood in their stool for the first time, for them to not send them away and say it's hemorrhoids. So I think eventually probably the age will be younger and younger for screening colonoscopy, or who knows, they might have other tests that are, really good too for screening. But I don't think right now it's still not quite it's still more common in older patients. It's just that for somebody like me who sees this a lot, I'm seeing so much more of it now at, 30 and 40 than I did 10 years ago. But I've had patients that are 18, I've had patients that are 28, I've had patients in their 30s, and a lot in their 40s. Like people that are my age in their 40s with kids my same age, that are my peers, So it is definitely a lot more common, but not to the point where they would all get screened. But I do think they need to be aware that if they are having symptoms, they cannot wait for their hemorrhoids to resolve or be doing sitz baths or whatever the treatment is for hemorrhoids and just wasting time, to get a potential cancer treated. So I think part of it will be an education of everybody, all the primary care, all of the kind of first line, the ER doctors. I've had patients who, get diagnosed, who are young, who get diagnosed with diverticulitis, and they have masses in the liver, and they just get called abscesses. They get sent out on antibiotics, no follow-up, never gets better, So there are those patients. I think for me, I see it a lot more because that's what I deal with, but they're definitely out there, and I think education through all of these types of things is really important. Yes. I agree. And that's the last thing from their mind, they're just, they're starting college. Who would ever, The patient that I have that's 18, that is a known hereditary family. So some of those patients that are really young do have a known like genetic, thing, like where they have cousins, they have other family members.
And then there's a close correlation to bleeding just before double.
Well, a lot of times they just get misdiagnosed, or they'll get a partial colonoscopy and they might have hemorrhoids because hemorrhoids are pretty common. But if you don't look at the rest of the colon, that's a missed opportunity because there's different ways of looking at the colon. They can just put a little scope in and see hemorrhoids and say, okay, they have hemorrhoids, it makes sense. Or they can do a full colonoscopy and maybe find something else.
Oh, thank you for your sharing, very informative.
Thank you.
I have a question about some of the treatment, like fecal microbiota transplant, and also hyperthermia. There's a focus ultrasound hyperthermia and whole body hyperthermia, and also photodynamic therapy, PDT, and proton therapy, like radiation, NK cell-based immunotherapy, and adaptive T-cell therapy, and more integrative therapy like mistletoe from European intravenous IV.
Thanks for the question. Those are a lot of kind of therapies that might be on trial. They're not like the standard line therapies. So those are therapies that might be used in conjunction to, the more standard therapies. Immunotherapy, though, is a really big one. There's a particular type of mutation that it's called MSI. So if you have MSI high status, immunotherapy works really well for those patients, like incredibly well. It can, take a CT with a lot of tumor burden to like 1 or 2 tumors. So there are some tumors that are very responsive to immunotherapy. If you don't have those mutations, they don't work as well. There are a lot of mutations that we don't know about. So people are starting to use immunotherapy more for like if somebody has a high mutational load, but not necessarily the known mutation for immunotherapy in cases where they've failed, chemotherapy, maybe a second-line chemotherapy that is approved. So, there are a lot of other sort of alternative treatments. They're not the standard yet, but can be used kind of as down-the-line therapy.
I would imagine that the insurance companies would refuse to pay for anything like a colonoscopy on a 25-year-old.
Yes, I mean, the insurance companies are, just a terrible thing, in my opinion, especially in especially in California, where there's a lot of these HMO insurances who are just trying to limit their care to their own centers. But I think that if you have a symptom like bleeding, they would cover it. Sometimes we have to do, as a physician, I do a lot of what they call it peer-to-peer discussions where they make an appointment for me to talk to the head doctor for some small insurance company for that pump, for the HAI pump. I have to do that all the time. Essentially, almost every patient other than somebody who's at UCI with us, they fight that therapy because that's not a super common therapy. Although there's a ton of, research on it, a ton of papers out there on it. But that's a really common fight that I have to have, and they have denied it in the past. So, yeah, there are some insurances out there that are really difficult to work with.
What do you think about Cologuard as a screening tool versus a colonoscopy?
I think it's not as good. It doesn't have as high of a sensitivity and specificity. It has a lot of false positives. I would not replace colonoscopy with that, but I have seen a lot of patients who get that test over and over instead of a colonoscopy, but it's definitely nothing like a colonoscopy.
Just kind of a simple question. Can you explain exactly what a polyp is? I mean, I know the word and I know that's what people find colonoscopy. What exactly is it?
It's an abnormal growth. So it's like a cluster of hyperplastic cells. They come in all sorts of different forms, like it can be a sessile polyp or a flat polyp, but it's basically an abnormal little growth of cells. And then they take a biopsy of it, or they remove the whole thing through the colonoscopy. So usually the polyps have not grown through the muscular wall of the colon, so removing them just removes the mucosa, which then, heals itself, and then they send it to pathology to look at the cells. And there's different types of, risk within the polyps. Some are low risk, some are higher risk. And then they go through the sequence of being a polyp to low-grade dysplasia to high-grade dysplasia, to then carcinoma in situ, which isn't an invasive cancer yet, and then the next step is cancer. And so for some cancers like colorectal cancer, it usually goes through that whole path. Yeah, some people have polyps and they're totally benign polyps, and then they do the colonoscopies based on like the number of polyps, the risk of the polyp, the size of the polyp, and those things. Yes, I definitely think you have to be skilled at doing the colonoscopy because, the colon is like a tortuous organ. You have to see all of the, they usually advance all the way in and then they look as they pull the scope out. So if they pull, too fast or something and a whole bunch of colon goes by, but I think most endoscopists are pretty skilled at it, but yes. Yes, definitely things can be missed on the colonoscopy, especially in the lower part of the colon. They have to really, retroflex the scope to look at the whole rectal area before they remove it. But, I guess I have seen some people who have, maybe get a cancer and they have had a recent colonoscopy and there's a question of whether it was missed or not. But for the most part, I haven't seen that much of it.
Well, thank you so much, Dr. Jutric.
Thank you so much. Thank you for being here. It was really fun talking to you. And really great questions, very thoughtful questions.
Yes. And let me remind you that this was videotaped and it will be up on our website and on YouTube. So if you share the knowledge you've gained here with your friends and let them see this as well. And remember to get your Colon Cancer Month ribbon before you leave here today. I see you have one, yes. And next month we will be doing memory loss. So I hope you can remember that. All right.